Okay, welcome everybody. This is the Pitkin County Community Health meeting for June 11th, 2020. It's our live broadcast. We're in the fourth month of responding to the pandemic in our community. And so far, quick report, as we've managed to flatten the curve and keep new cases to a minimum in the community. And that's because we've been following the 5 commitments to containment: washing hands, wearing face masks, social distancing, staying home if sick, and getting tested if symptomatic. So the community is doing a great job and has been. There has been an outbreak recently in the Mid-Valley that involved a handful of grocery store workers that created a demand at Aspen Valley Hospital by citizens who are worried that they might have been infected by shopping there. AVH is not testing people presently who have had no known contact with, let me say that again, AVH is not testing people who have had no known contact with known cases or are showing no symptoms. And Dave Ressler is going to join us on the call at some point, and you can clarify. Tracy Truelove is here with us, and she's going to talk about the contact tracing protocol that's being followed in this instance. Suffice it to say that if you've had any risk of being exposed related to the Mid-Valley cases, you will be contacted by one of our contact tracers. Pitkin County has contact tracers, as do the other counties. So you would be contacted if it seemed that you were at risk and on the contact list. Because we're in the midst of a pandemic here and around the world, it's happening everywhere, outbreaks like these in our community should come as no surprise. They really shouldn't. This is the new normal, if I can use that term. It's easy for us to become complacent about this. And so what we want, we'd like it all to go away, and we'd like to get back to our normal lives, but now's not the time to let up on the practices that we've had here. So it drives the point home, we're not out of the woods yet. We need to continue to embrace the 5 commitments, not just to protect ourselves and our families, but to protect the workers who are serving us at the grocery stores, retail establishments, restaurants, bars, etc. I'm going to turn it over to Tracy now, and we'll talk more in detail about our local contact tracing efforts. Take it away, Tracy.
Great, Greg. Thanks for saving me there at the beginning. I've probably done about 10 of these now, and I've never had technical difficulties, and today wasn't one of those days. So I appreciate you jumping in. What I don't have for you, though, which is I'd like to show, but I know you've also seen it, a lot of our community has seen it, is our box it in strategy slide, because that's really what public health has been putting in place to meet this very situation that we find ourselves in the Mid-Valley. And so it's important to understand that public health has been expecting and preparing for the possibility of an outbreak to occur. And this is what should be expected once we start lifting suppression, right? I was in town yesterday. I see it's a lot busier than it was a few weeks ago, and we knew that this is what we were preparing for. There's a methodology around case investigation and tracing, and that is the discovery of information, which allows us to understand the full scope of the outbreak. The box-in strategy is designed to support this outbreak, and all the steps are being taken to trace anyone that could have made contact with the impacted parties. It's also important to understand that part of that strategy is that the public health team will reach out to you to guide you through the steps if there's a potential you've been exposed to coronavirus. So we kind of want to remind folks to not just start calling, I think Dave will appreciate this, not start calling Aspen Valley Hospital because you've recently been, shopping in the Mid-Valley. We could see this happen in other places in our whole valley and in the community. So it's the way that contacting, tracing, and investigation is set up is that someone from public health will contact you, and they will walk you through the steps if there's a potential you've been exposed to coronavirus. And again, the box-in strategy steps are testing, isolation of the person who's been, tested positive, to the contact tracing. Again, we talk about the concentric circles, and Karen Kenneman had touched on this many, many times in the early stages of the outbreak. So I just think we're here to remind folks what that means and looks like. But again, anyone who might have been in contact with folks that were tested positive or exposed. And I think it's important for the community to understand the public health team has been working to build out a robust team of contact tracers and investigators, and is working collaboratively with other jurisdictions around this current investigation and any future outbreaks that could occur. So that is always what we've been getting ourselves prepared for, because we know we're not done, right, with where we're at in this whole situation. And so with that, I'm going to kick it over to Dave, because I think he's going to give us an update on where Aspen Valley Hospital is. And again, I apologize. I spent 15 minutes trying to figure out how to get in, and maybe I need an update. That's probably what's going on here. But thank you for your patience. And Dave, if you want to take it over, I'm going to send it over to you.
Great. Thank you, Tracy. Can everybody hear me okay? Great. My video is poor. I apologize for that, but I look better in the dark anyway. I had to do some adaptations here. I'm going to try sharing my screen so that we can walk through the current status at AVH. So that should be coming on now, I believe. Great. Can everybody, there it is. Okay. So let me, I also have some questions that I want to make sure I answer during the course of the presentation. Thank you for those that sent those in. And let me just start by saying that, as we all know, the roadmap has 5 criteria that must be met before we move to each phase. And I'm just going to touch on a couple of those today to try to zero the conversation in on what we think people want to know about. And the first of those, it's actually the second criteria after our numbers of cases being effectively suppressed. That's the first criteria. The second criteria is that the hospital must be able to safely treat patients without resorting to crisis standards of care. A crisis standard of care, by the way, is way beyond where we want to be. That's essentially when you start rationing. So we're certainly not even going to let it get to that point. So what are we going to do to monitor our levels of activity and the hospital's capacity levels? And that is expressed in this matrix, which we developed in cooperation with public health to be able to provide a real-time assessment of the hospital's capacity. And this is where we've received some questions that I want to answer. And then I'll talk a little bit about testing. So first, to describe the matrix in summary, the far right-hand column is where we would like people to focus their attention. Everything else is essentially explanatory and setting some criteria. But in the far right column, you can see right now we're comfortable as it relates to 3 different trends that we will be observing. The first one is inpatient hospitalization. The second is the amount of activity in terms of daily visits. And the third is the availability of our workforce to be able to take care of our patients. And in each case, we describe our capacity, our capacities in the column second to the left. And then we talk about at what point do we move from being comfortable to cautious, where that would be reflected in that far right column. And that's if in each case, we trigger the criteria. So for example, inpatient hospitalization, if we get to the point where we only have...
Interrupt here?
Yeah, please.
A request to get your screen to full mode instead of the presentation notes. So if you go to view or display settings.
Yeah, I thought that was just me. Display settings.
Pardon, maybe not.
Yeah, you know what, yeah, if I move this one. I apologize.
That box at the bottom where it shows half of a screen, and what does that say?
Or go back to display settings and hit the top option. The first option is swapping between the two.
That'll do it. That ought to do it. There we go.
Beautiful. Now our folks can see it at home. Thank you, Dave.
Greg. All right. Yeah, thank you, and I apologize for that. So now hopefully it's easier to see that which I'm describing. And I think I was on inpatient hospitalization, that if we get to the point where we have less than 50% capacity, we're cautious. And if we get to the point that we have less than 25% capacity left, we're concerned. And that's the point at which public health as well will be taking a look at what may need to occur with regard to the roadmap or the plan. Cautious is the point where we hope the community will take notice. And going back to Greg's comments at the beginning, it's really our social responsibility and all of our individual responsibility to help keep this virus at bay. And cautious is saying something's going wrong because we're starting to see too many patients. So let me answer a couple questions that have come in that I think are excellent. The first one is, really, I'm not going to repeat the whole question because it's fairly long, but it's related to that inpatient capacity. And if you look at the second from left column, you'll see how many beds we have available. And it's if those beds start to become full to the extent of limiting our capacity that we're going to be concerned, and taking into account that we have 5 ventilators available, of which 2 we want to maintain for transport availability. Because I want to make a point of saying what I've said before, and that is, it is not in the patient's best interest to stay at 8,000 feet if they're on a ventilator. They really are best served at a lower altitude and at a hospital that's typically larger and more accustomed to managing ventilated patients on a long-term basis. But having said that, we may not have the ability to transfer patients if they are becoming full. That's when you start getting into a systemic gridlock for bed availability. So I'll try to answer the question that really gets into, we actually have a total of 8 negative pressure beds, 8, 4 in the intensive care unit and 4 on the patient care unit. We don't have to have patients in negative pressure rooms, but that's the best place for an infectious patient to be for the safety of all of our other patients. But we will move patients around. We often will keep patients in the intensive care unit simply to keep them in one location, all patients in one location, when they're actually not in intensive level of care status. So we reserve some opportunity in defining how much of our capacity we have left it's for us to make that determination based on all of these factors and where we're choosing to keep patients and how we think they can be best managed. So that is somewhat of a subjective assessment at how much capacity we have left based on how we're able to move patients around between units. So I think that answers the first question. The second question is with respect to the visits on a per day basis. There again, I think some community members are trying to interpret these individually, and our intent will be to take them all into account. So for example, we might be seeing a lot of respiratory tent patients, but not a lot of emergency department patients or patients that are CT, which stands for community tests, and not be that concerned about it, or vice versa. Maybe our testing is up, but we're not seeing a lot of activity otherwise. We're going to take all 3 of these into account when we determine if it's necessary to move to the cautious level. But generally speaking, you can see in each one of them individually or distinctly how much capacity we have on a daily basis. So hopefully that answers that patient as well. If we start just by way of example, in the respiratory tent over time, not just in one day, but our trend is we're seeing 15 patients, 12 patients, 13 patients, and the emergency department is starting to see 7 and 8 patients a day. We're likely going to say we're now cautious. We're starting to see a trend of patient volumes that are starting to make us feel like we're getting to the point that our capacity levels are being threatened. And then finally, essential healthcare workers, similarly, we're just watching the number that are out, and that's a little bit more hard and fast. But what we define as an essential healthcare worker allows us some flexibility to shift staffing around to meet our needs. So that is what we're trying to accomplish with all of this. And I don't know if we're taking live questions, but I'm going to move on to testing in the interest of time. But I would just like to recap and say, please just keep an eye on that far right column. And if you see a cautious, the first thing we should all be thinking about as community members is, are we doing our part to limit the transmission of the virus?
Great. Thanks, Dave. I think we'll open it to questions afterwards, just after the presentations are done. And I think we probably will have some people calling in with questions.
All right. Sounds great. Thanks, Greg. All right. And we remember now that the third criteria to being able to move forward is being able to conduct testing, which we are. And we're very proud to be participating with Pitkin County Public Health to be able to do that. So as we remember, testing of symptomatic patients, any amount of symptoms, is the first step in being able to identify patients that have the virus so that we can then box them in. And it's important to note that we want to be able to have symptoms because that's when there is the suggestion of a viral load in the body that will be picked up by the test. So there are circumstances in which patients don't have any symptoms and yet they're positive. Those are asymptomatic patients, but they're generally not common. We are really trying to focus our efforts on those that have symptoms that will suggest that they have the virus. So the first thing to do is, if you need assistance with managing the symptoms, call your primary care physician. Or if you're really having difficulty breathing or really concerned, come to our emergency department and we'll take care of you here. And the tests will be done here. Your primary care physician may refer you to the hospital, to our respiratory evaluation center, and be tested here as well. If you're having moderate symptoms, and we have physicians on site that can help you with your condition. For those that have minor symptoms, they feel tired, malaise, sniffles, they're just not sure, we still want you to call your primary care physician and let them decide if you should be referred to the Respiratory Evaluation Center. By the way, it used to be a tent, and now it's moved in-house because of the summer weather conditions. It's in our old emergency department, so that's why we changed the name from a tent to a center. But your physician will refer you here for a test if they think appropriate. Again, we are using nasal swabs, and some exciting news that we have here is that we now have the ability to test immediately in-house in our laboratory so that we get results within 45 minutes rather than having to send them out to get results back. So we will know whether or not your test result is positive very soon after we collect the specimen. Then we are asking our patients to self-isolate. If for some reason, this actually should be corrected because we're now getting the results rapidly. But until you have follow-up, if it's a positive test result from public health, who will talk to you about who you've been in contact with, and they will start the tracing process. Important to note, negative results are not any assurance that you don't have the virus or won't be developing the virus. There is a 25 to 30% false negative rate still with the tests. So that's why we go back to our 5 commitments. Still, wear your mask, keep your distance, et cetera, even if the test is negative. This is the process. If you do not have a primary care physician, I should have mentioned this earlier, call 279-4111, and you can be provided access to one of the primary care physicians in the Aspen Valley Hospital primary care practice, and they can refer you to the Center for performing the test here. Pointedly, if you do not have insurance, don't worry about it. There will be no cost to the patient for these tests. And if you have insurance and they don't cover all of it, there will be no cost to the patient for the test. We are going to bill insurance because they need to pay their fair share in the system. Anyway, okay. Of all of the tests we've done, for the purposes I just described, the community tests and those that we've been treating, we've now performed over 554 tests in total. 27 of those have been positive. That is a rate of 5%. What does that mean to us? That is a low rate, and the good news about that rate is that the state epidemiologists say that if you're doing enough testing in a community, you should have a 10% or less rate of positive tests. So we're half that. So what that suggests is our community is doing not just a sufficient amount of testing, but a generous amount of testing. So thank you to our community for coming in and getting tested when you have symptoms. It's working. We should have a strong surveillance effect. A question was asked, are local positive tests that are done at a doctor's office considered part of the load? And the answer is yes. When they're conducting PCR tests, that's Dr. Allen in the Mid-Valley. She's actually on our medical advisory team, and those positive results are included. There was another question about testing, but I'll go ahead and see while I'm looking at those that have been sent in if there are any. Is this now, Greg, the time, or did you want to wait till the very end of the total meeting to take those questions?
Well, while you're on it, go ahead. Why not? If you're on the topic, go ahead.
Okay. One of the questions was, why is the number of community tests per day a metric? That's not within the chart that I just shared. That's within the, that is, pardon me, in the chart, in the matrix that I just shared. It's just in general, we're looking for activity of people having to come to the tent. We think it's a pretty good indicator because if the virus starts spreading, there will be more symptomatic people, and it's just one indicator. But as I pointed out earlier, we're also looking at the number that are coming to the emergency department and the number that are coming in for treatment in the respiratory evaluation center. If only our number of tests go up, we may not be inclined to move to the cautious level. It's just one of several indicators, but generally speaking, again, if there's viral spread in the community, you're going to see a lot more people with symptoms in general. One question was, why cannot all the metrics that the decisions are based on be charted as part of the daily update? Why is only positive tests being reported? The simple answer to that is because we want to be looking at trends, and the determinations about when the community is starting to see an uptick in the viral spread is multifactorial. So we provide the positive tests because, as you can see, there's not that many, 27 so far. So if all of a sudden we start seeing bing, 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 positive tests, that is an indicator clearly that the virus is being spread. But all of the other data that we have been providing on a daily basis, like how many patients are in the hospital on a given day, really isn't helpful because it's a multitude of factors that goes into determining our capacity, as I think I explained earlier, and it really wasn't helpful, we didn't think, for the community to be trying to decipher hospital operations in that regard. I think I have answered all the questions. There was one about whether or not we have the right greater than or less than sign in the matrix, and I believe we do. I double-checked that. It still seemed to make sense, at least to me. If whoever asked that question maybe is not understanding the chart, happy to take an individual question about interpreting the matrix. So I believe I've covered all of the questions that I had.
Great.
More.
Thanks, Dave. I appreciate you being here, and maybe more will come in. Now I want to introduce Nan Sundin and Chad Federowitz, who are from our Pitkin County Health and Human Services and Senior Services. I think that's why you're here today, Chad. But, take it away. It's on you now. You've got some slides for us. You have to unmute, Nan.
Yeah, thank you. Yeah, thank you. I'm Nan Sundin. I'm the Human Services Director, and I'm here with Chad Federowitz, who is the Senior Services Manager, and he's also responsible for the formal emergency support function 6, which is mass care and shelter. So today what we want to do is just share briefly with you what we've been doing, who we are, what our structure is, and how we're working with the community partners to move forward into helping individuals and families become more resilient, having been impacted by COVID. So next slide. Chad's managing the slides. Oh, look at, I can manage the slides too. Oh, thank you. So the normal human services functions include the senior services, which is meals and transportation and programs over at the senior center. We have protective services, which is adult and child protection, really focused on prevention and intervention. Economic assistance, which is where we do all eligibility work for what we would call a welfare program. Medicaid, SNAP, food assistance, Colorado Works, LEAP, which is low energy assistance program, all of those programs. We're responsible for veteran services, where we provide, with a veterans officer, assistance with claims and resources for veterans. And then finally, in our division, we're responsible for the Healthy Community Fund, which is a dedicated property tax that brings in, and we distribute about $3 million a year to support what we call the social safety net. So that's public health, senior services, all the mental health programs that we support, youth and family services, legal services, our community nonprofits, and our environmental groups. Okay, thank you, Chad. Oh, now I have the power, maybe. Got it. So in March, our duties doubled. So we had all of those duties that I just listed, and then we went into emergency response with the incident management team. And our responsibility in what they call emergency support function 6 are these things. So our job is to ensure safe and adequate shelter and housing during an emergency, providing mass food and supplies, coordinating mental health response and resources, supporting people with what we call, it's a formal term, access and functional needs. But really it speaks to people over 60, people who are disabled or disenfranchised, homeless, unemployed. In this pandemic, there are a lot of people with special needs. And so we're responsible for making sure they get what they need, they don't go hungry, they have housing, they're safe. And if they're sick, we try to get them supplies that they need at home. We're responsible for enhancing youth, family, and individual well-being through a number of ways, including childcare, supporting programs for school-age children and families, and then, as I said, ensuring the continuity of all of our normal services. So, Chad.
Sorry, I had to figure out how to unmute myself. Yeah, so thanks, Nan. So with all of that work that Nan kind of described, we work with a number of community partners in kind of our response efforts. We kind of broke down these areas into kind of different categories of access and functional needs, housing and shelter, food, families and children, mental health, and financial assistance. And so this slide just really highlights some of the different community partners that have been assisting or kind of doing this similar type of work. So the idea of human services or emergency support function 6, responding to a disaster or emergency, is really the efforts of the departments, but also all these different community partners, nonprofits, and other organizations providing very similar services in their own rights that provide that kind of broader social security net that Nan mentioned.
I lost a little, oh, there we go. It's hard there, got it. So we'll just start with our response to the homeless and the people with special needs. The first thing that we did was we set up a case manager to help us reach out to people who maybe were hard of hearing or had special needs, couldn't complete applications, didn't understand what was going on. And we used case management to support those people one-on-one. And it's something that we do normally, but it was expanded by, about 10 times. In our response for the homeless, we had let me get into the second one. The second thing that we did was we applied to FEMA to have a designation through their public assistance program called Medically Necessary Non-Congregate Shelter. And what that does is that it allowed us to contract with a local hotel and provide services to 3 specific populations and put them in a hotel. The first population is people who have become COVID positive and couldn't go home and isolate at home because of overcrowding or the housing situation or whatever. The second is people who have been exposed to COVID who can't quarantine safely at home for whatever reason. And the third population is generally people over 65 or others who have underlying conditions who are at risk of contracting COVID and don't have a safe place to go home and quarantine. So we've been able to set that up. So far, we've had less than 10 people in the hotel, but it's been a great option for us, and it remains open every month. The state applies for an extension with COVID, so we're now extended through June 8th for this program. We also immediately set up an emergency overnight shelter at the Human Services building on March 14th because St. Mary's needed to close their shelter because of the directive from the Archdiocese. And we used the Health and Human Services building. We worked with the Aspen Homeless Shelter. And at first we had about 10 people coming in nightly in March and into the beginning of April. In April, we saw that there were a number of homeless people who were not coming into the shelter for a variety of reasons. Some didn't want to sleep in congregate shelter. Some have had, maybe are not welcomed at the homeless shelter. So for whatever reason. So we initiated the safe outdoor space at the Intercept lot. And we set up a camp with a lot of help from the ski company and City of Aspen and other volunteers, Town of Snowmass Village. We got fences from the ski company to create campsites, and we set the campsite up with bathrooms, wash stations, bear-proof food containers, some propane tanks for heat and for cooking, and solar showers. And we hired a camp host. At this time today, there are 17 people who are staying at the Intercept lot, safe outdoor space. And what we've heard from everyone is that it's working really well. The people who live at the safe outdoor space are keeping it clean. It's orderly. There are very few problems. The camp host is doing a good job ensuring that everyone's practicing safe social distancing and all the practices that we require, including temperature checks and all of those things. So those are the primary ways that we've been serving our most vulnerable members of the community. Chad. So we just wanted to show you some data that reflects some of the significant increases that we've seen. SNAP is the Supplemental Nutrition Assistance Program. It's for low-income people, generally people who are making less than 135% of the federal poverty level. And you can see with the chart on the left, the SNAP caseload, that our SNAP caseload increased about 62% during this time, up to 293 active cases. We generally average about 180. Our SNAP applications are up about 638%. Not everybody qualifies, but our job is to do all the due diligence to determine that. There's something called expedited SNAP applications, and that means we have to determine within 7 days based on the way the application comes in, and that went up about 577% from 88 cases. 288 cases, we generally have about 13 a month. And the average SNAP issuance is up. So what that means is the amount of money that people, once they qualify, they get it on electronic benefit transfer cards, like a little debit card. So with some of the extra money, what the state did was they decided to give everyone 100% of the SNAP benefits right away. So you can see that the amount, generally, the average was about $229 in the chart below, which is up from about, generally, the average is about $164 a month. And the last part is, just to keep in mind is that SNAP brings money to individuals, but it also brings money to the community. So we pre-COVID, were generally able to issue about $30,000 a month in SNAP benefits. And in April, that went up to $90,000. And that's money that goes to our grocery stores and it brings money into our community as well as helping individuals. Okay, thank you, Chad. The next slide is the program that we started for COVID emergency financial relief. And a lot of people know about this program. These are 3 charts that sort of show how we serve this population. Prior to COVID, we had a program called Emergency Assistance, and we issued about $40,000 a year. In the last few months, we've issued over $2.2 million, and that's in rent assistance, food assistance, utility assistance. If you look at the first chart on the left, you can see that the blue is the shelter. So we've been helping people with rent, and that's about 78% of the funding that I just mentioned. Smaller portions for food, the yellow, and cash to help people pay their utilities or other bills. We actually increased our eligibility team from 5 to almost 50 to manage this workload. And we got a lot of help from the library, the clerk and recorder, finance, our IT department, and also temporary hires. And also want to shout out to the ski company, who were the first group of volunteers who helped us start calling people right away in March. And we couldn't have gotten through. We approved over 2,000 cases. The 2,800 unduplicated individuals have been assisted with 520 children involved in that. So it was a huge lift, thanks to the City of Aspen, Snowmass Village, some private philanthropists, Aspen Community Foundation, and Pitkin County. It just has been amazing. We continue to provide this funding. But because people are getting stimulus checks as well as unemployment benefits, they don't need the money right now. So we're really doing more means testing and providing the funding to anyone who qualifies, including people who are undocumented. We have taken the position that shelter is essential in a disaster, and we will fund anyone who qualifies financially for that aid. Okay, next slide.
Okay, that's me. And so on this slide shows kind of the efforts around food distribution within Pitkin County. It's a combination of mobile food pantries that were set up in Snowmass Village, at the Basalt Middle School and the Aspen High School, and then along with the meals that are provided at the senior center. And so really this is a combination of efforts between those locations with Aspen Family Connections, Lift Up, Food Bank of the Rockies, Aspen Ski Co., many different community partners coming together to provide food for the community. And so, you know, looking at toward the end of April, early May, we see we served almost 2,000 households of food just from these 4 different areas. So, you know, I think this tells a really great story of the collective efforts that came into being rather quickly around getting food out to the community, not knowing exactly, you know, how long different things would be going on. And so moving forward, not shown in this graph, but moving forward, you know, we are working on efforts with these different partners I mentioned toward reopening the Aspen Lift Up location and getting full-time staff there, as over time some of these mobile pantries may close or shift, and really refocusing some of our efforts around getting that Aspen Lift Up location back up and running. And then here for human services within the framework of this emergency support function of mass care and housing, we slowly started to shift some of our thinking and our efforts around recovery. And so we kind of have framed some of our thinking around the ideas of supporting the public health departments with their goals and objectives. So all the things that Dave and Greg and Tracy talked about earlier. And then shifting to kind of our normal work or our normal lines of thinking around sustainability of the community programming and partnerships, both from a more shorter term, a few months, to a longer term, 12 months, et cetera, what that could look like. And really thinking about ways to better support individuals and families around their economic stability. So thinking through that lens of our economic assistance department, some of the information that Nan was sharing, and then also our continued efforts and work toward focusing on those higher risk or vulnerable populations that may just need a little more assistance or help in the current situation. And kind of along those lines, as far as an example of shifting how we think about doing our work here at Senior Services, we really want to focus on how to socially support older adults. We do more than provide meals. And so one of a few things we've done is to shift our programming, since the Senior Center is closed, most likely for the foreseeable future, to shift our programming to a virtual platform. For those older adults that have the ability and access, they could go onto our website and find a long list of resources that we continually add to. And we know that not all people, let alone older adults, either have computers, have access, or know how to use them. And so we are coming up with other ways, working with some community partners, to really kind of still socially engage and engage with those older adults that may not have the means to use this particular resource. I'll hand it back to Nan.
Yeah, so we're done. We'll turn it over to Tracy and take questions.
Great. Tracy, if I could, I had a couple questions that came in for Chad and for Nan. Maybe we could start with those. One, Nan, is regarding the economic and food assistance redundancy. We have pantries up and down the valley. Are we able to track how people are using them? Are people able to go to multiple locations? And if so, is that happening? And are we able to track that? That was the first question.
Yeah, thank you. We are starting to track some of where people are coming from, and we're also starting to map where people are receiving some resources, so that we can target better to neighborhoods and communities. Families can go as often as they need. Nobody's being turned away. In the very beginning, people were turned away because we didn't have enough food. And like in March, early April, we could not anticipate the demand. And, but I think we're on top of that. And Food Bank of the Rockies has been extraordinary in the Upper Valley for us in helping.
Great, thank you. If I could, I wanted to report that I know we're starting to see food from local farmers coming online. That's been a specific interest of mine, where the food pantries that Lift Up is running is starting to receive locally sourced eggs, dairy, meat, and produce. I think they just took an order of 1,800 dozen eggs, for instance, and we're able to pay cash up front to the producers to keep money flowing in our local farm economy. And I know greens are arriving also, so they're able to provide the pantry with greens. Another question I had just regarding economic forecasts. I appreciate you giving that to us, and that's a question we had with Nan earlier in the week. I understand we'll be getting a presentation on economic forecasts for assistance sometime before the VOCC in the next month or so. Could you tell us who's coming to talk to us?
Yeah, we're going to be working with Jessica Valland, and it looks like it will be on July 21st, I think, or something like that, due to some schedule conflicts. So, you know, what we're really looking at is that our unemployment rate is still over 20%. And what we anticipate is that people are going to lose the stimulus piece of their unemployment, and that's $500 a week. And they may or may not go back to work, or they may go part-time, or businesses are going to find a way to work with fewer people because they have an economic drive as well. So we're looking for Jessica to come in and talk to us about, you know, what the forecast is for how we work towards building new skills for workers, maybe global skills that they can use in a different way, what businesses are going to be looking for, and how we try to focus on that in the community.
Great. I really look forward to that. Chad, I had one other comment just for me as well regarding seniors and devices. Having taken Senior Center online, I know it was really tough for a lot of older people. As I get older, I find I have more and more trouble operating devices. And I'm hoping that there's some way we can keep helping people adapt to these things so more people can use them. I'm just hoping there's a magic bullet out there for senior-friendly, you know, iPads. Even one button can be confusing sometimes, or more confusing. I don't know if you have anything to add to that, but I'm hoping we find solutions for our seniors who are device adverse, I guess is the word.
Yeah. Unfortunately, there isn't a magic wand to wave on that. And, you know, I would say it's not just older adults that may have issues. You know, many people that aren't older adults have issues with technology. You know, Tracy couldn't get on this call. You know, but I think, you know, I'm optimistic of some things that we're working on, thinking about. So I had a conversation with someone right before this call about, what are some other creative ways we can do about getting technology into the hands of older adults and supporting them through that process.
Great.
So
well, thank you. I look forward to hearing about that. Tracy, I think that's it for my questions. Over to you.
Yeah, I want to actually go back, and I know Dave wanted to make a clarification on something that might have got missed in his presentation. So Dave, I'm going to kick it to you.
Thanks, Tracy. I got a call after I was done presenting asking for clarification about something I said. So I thought maybe others might benefit from that clarification as well. And that was when I was talking about the matrix, and I was talking about what it might look like for us to go to cautious, I was intending to provide an example that for our daily visits to the emergency department, the respiratory evaluation center, and the community testing, I gave examples of numbers being higher than the cutoff to go to cautious. And at least one of our listeners, but I suspect more, thought I was actually saying that's what we are experiencing today. And that's not the case. We are still seeing low numbers of patients in our emergency department respiratory evaluation center, and the tests I just checked this week, average of 2 a day in the emergency department, 3 or 4 a day in the evaluation center, and about 6 a day tests. So we're running right where we've been running. We haven't started to see an increase yet. And so we remain comfortable in all categories. Pardon me for talking too fast. That's probably what led to the confusion.
No, thank you very much for making that clarification. I might ask Jordan, our Wonder IT help today, if we have any Q&A coming in from our listening audience, because I haven't seen anything yet. So maybe I'm missing it.
Tracy, we are not seeing any Q&A questions at this time.
Okay, well, thank you. That may suggest that all our panels did a fantastic job of covering a lot of really great information. I will go back to the panels real quick before we get ready to sign off. We did a great job. We're about 4:55, and we try to do a hard stop at 5 o'clock, and we're almost there. So Chad, Nan, or Greg, or Dave, is there anything you'd like to close with?
I have a couple things I would add, if I could, but I want to make sure I don't take up all the time. Does anybody else have anything else to add here? Well, thank you all for participating. The first thing is just to remind people that the voluntary symptom tracker that we have on our pitkincounty.com/COVID-19 page, if you just go to pitkincounty.com, you can find it. That voluntary symptom tracker has been very valuable. I think it's proving valuable around the world in communities everywhere. It's helping understand the spread of the virus or the control of it. It's become very useful. And so I would encourage people, if you do have symptoms, or even if you don't, you're encouraged to fill it out because it helps. The data is really helpful. It doesn't take any private information. It's not going to share private information. So you don't have to worry about that. But there's also an form for an emotional check-in. That's important as well, because as everyone feels, there's a certain ambient stress level that's been elevated for the last several months. And I think it's important to check in with that as well. That same page also has volunteer resources. The other thing that I would like to share is that it's been on my mind a lot lately. It's just, and I want to say the local businesses which will thrive going forward understand that, one, I don't think the police department or the local government is going to have 100% effectiveness at controlling or enforcing or informing even as much as we try regarding social distancing and all these rules. And it's really going to come down to the customers and the clients of the businesses who are going to be paying attention. And I think in our community, where we have a lot of affluent elder people who people over the age of 60, 65, we have a fairly high demographic of older folks here that spend a lot of money in our town. And they're going to be watching the restaurants and the bars and the businesses. And if they don't feel safe, they're going to be making their decisions on whether or not to go in. Just as an example, today, earlier, a very active longtime local resident said, he's going to avoid going to such places if he doesn't feel safe, if he's not convinced they're following the public health rules and the rules of hygiene as seriously as he thinks they should. So being unique and that we have many affluent older people here, their patronage is what keeps us going in many cases. So I think everyone should bear that in mind. And the other thing I just wanted to point out is that the rapidly changing circumstances of the COVID-19 pandemic and the economic recession as a result of it are kind of hard to get used to. And we're all doing our best to be resilient and nimble and to adapt quickly to the changes. And as a county commissioner and as a vice chair on the Board of Health, I just want to say that we're doing our best to stay on top of all the recent developments which we hear about. We're examining the health protocols and technologies which we hear about, and we're listening to our medical and public health advisors as they recommend courses of action and to keep the community safe. And these are really exciting and interesting times in some ways. Interesting can be a threatening word, I think, in this case. But the new opportunities for how the public is served and how we handle these circumstances are emerging. And I think if we're all open to the changes and the intentions behind them, I think that we're going to come through this and we're going to be fine. So I also wanted to say it's great news, for instance, the nimble, resilient aspect is driven home by that now we can get a test at Aspen Valley Hospital and have the results within 45 minutes. So thanks, Dave, for sharing that with us. This shows the technology really is, it's evolving rapidly. And so once again, that ambient stress level from being uncertain about what's happening is really changing on a daily basis. But I think it's for the better for now. So thank you all for that. And I don't know if anyone has anything else to share, but I'll let Tracy close us out.
No, thank you, Greg. And panels, if you'll stay on, I want to be sure I get your slide decks because we like to do a wrap up that we post on the website and on the Pitkin County Public Health Facebook page. So if you guys don't mind sending that to me and you stay on, I'll be sure you have my email. No, again, thank you to our listening audience. We've moved into a different cadence about timing and when we're doing these meetings. So next week, there should be a scheduled Board of Health meeting, and we'll be back with a community meeting that following week, so 2 weeks from now. And in that one, we're really going to bring some of our epidemiologists back to do, again, a much deeper dive into where we're at after we've had kind of, again, that 14-day window to see where the numbers are tracking. So thank you all for being here today. Chad's right. I was challenged today. It's always throwing you something new, isn't it? So have a great night, and we'll see everybody soon.
Thank you.